Well, thank you for the introduction. And the only thing you left out is we do also train IV sedation, so you can get licensed in your states via the IV sedation. My name is Dr. Dhoon, and this is Dr. Briskie. We're coming to you from Colorado Surgical Institute, and we are going to be talking about how to never have a spinner again. And so from a clinical focus perspective, we're going to focus on how to consistently achieve stability. We're going to focus on the bone and the flutes of the drill. So this part I can't stress enough. This is one of the major takeaways I want you having from this presentation is as we're drilling, we're analyzing the bone and the flutes, so we're making real-time discoveries about how we're going to handle our surgeries. And then the third is the technique on placing your implants at 45 Newton centimeters of torque. What we want to do is challenge the industry standard of 20 is okay, 25 is okay. Dr. Briskie is going to talk about in depth about why 45 is going to be what we're going to want to achieve on every implant, and we're going to talk about why that's going to be important. So the key concepts for today's presentation is we're going to cover the true cost of an implant failure. And I think it's going to be surprising for a lot of us to see what the true cost of failure equates to from a business perspective. Two, we're going to talk about how do surgical errors contribute to dental spinners, what type of implants to stock within your practice, how to deal with the spinner complications, is pressure necrosis a myth, and what are the practical strategies to reduce implant failure rates. And so this is a case that Dr. Briskie did recently. She had D4 bone, and I'll let Dr. Briskie tell the story. It's quite a remarkable turnaround, and these are the cases that are going to present in your practice all the time, and hopefully through the concepts you learned today, you can take these things home and on Monday morning, implement this in your own private practices.
So I had this patient, her name is Jean. She came to my practice about 8 weeks ago. And when she first initially showed up, she came in tears. And she's had 4 surgeries already, where she had 4 implants placed, 2 had failed, another 2 placed, another 2 failed. Shows up to my practice and radiolucencies around those implants as well. So we started thinking, well, what happened, right? Is this due to patient issues or is this due to a surgical error, right? We started making an analysis. I think it was a surgical error. D4 bone is notoriously hard to get stability on, right? So what I want to focus on is encouraging everyone in the room to just be humble and say, hey, maybe it was actually my hand skills, maybe it wasn't the patient, right? So always look for humility in these types of cases. So here's Jean. She'll light up a room even without teeth. Takes her dentures out. She was so embarrassed with her denture in mouth, she'd rather smile without her denture in her mouth. So she has lots of confidence. And she said, Doc, if you give me teeth, I'm going to go to Hawaii in 2 weeks after that, and I'm going to get married. She's actually in Hawaii this weekend, getting married. So I was really excited to see that. Here's her transformation. This one's the day after. And we placed 6 implants. So we placed 2 pterygoids and 4 implants in between, and we got stability in all the implants.
I'm so numb still. I can't smile.
Here's a little bit of stuff.
These look like real teeth. I'm so grateful. Thank you all so much.
You're welcome. You're welcome.
I'm gonna go home and smile. You think my dogs will recognize me?
Yeah.
They look beautiful.
Thanks to the man.
So one of the things that she said was, even my dogs will recognize me. I thought that was very powerful, right? So when a patient walks into my clinic and you see that there are some complications happen before, I get a really big smile on my face. I'm thinking, oh, you know what? I can fix this for you, all right? I have the hand skills to do this and deliver you a nice smile so you can go to Hawaii.
And so what we're going to talk about is just the antiquated beliefs of what dentistry used to hold. In order to challenge the constructs of what we are applying today and try to push the envelope forward, I think it's important to understand where we came from. Because if we can look back and say, okay, here's the things we've overcome just in one generation of dentists, then we can have the confidence to look forward to see what we can actually achieve. So GPs can't do specialty procedures. I know a lot of us have heard that. There's a lot of GPs who are doing zygomas and pterygoids and doing it very successful. And there's a lot of oral surgeons and periodontists and everyone doing those procedures very successfully as well. I actually graduated with a guy who's OMFS. We were good buddies. We lived together. And when I started my whole journey into surgery and I was doing vertical sinuses, we were having conversations and comparing cases. Then I started doing laterals, and he was like, hey, hold on a second. And then I started doing my first zygomas and pterygoids, and then he threw up his hands. He's like, hey, you can't be doing this. This is not part of your focus. And I think from the perspective of challenging that contract, I think everyone in this room would understand that that is now an antiquated belief. Dentists can't treat sleep disorders, right? This is one that I think we're currently in. I'm going through education right now in terms of MARPEs and MSEs and maxillary expansion techniques and SFOTs. And so different things that we can do from a sleep perspective to increase the quality of our patients' lives. I still think from an airway and orthodontic perspective, those two communities are just figuring out how to communicate together right now. Really antiquated one is men are the only ones who can be doctors, right? And we know how antiquated that one is and where we are today. Or Invisalign won't be as good as metal brackets and wires. So from that perspective, I was doing Invisalign 12 years ago, couldn't really do too many cases. Fast forward to where we are today, and I think I can do any single case with Invisalign as long as I have compliance. Or we're in the whole construct of milling will always be better than printing. I think the technological curve on printing is so steep that it's going to eclipse milling at some point in the near future. Or, currently speaking, tie bases are better than MUAs, or direct to MUA. There's some dogma that comes with each one, but I think both modalities can work really well. It just depends on whose hands that they're in. So what's the true cost of failure in your practice? So we're going to go over some numbers. We're going to do some math. Just remember, these are just general numbers so we can all have an understanding of where the dollars and cents are going within our business. So if we place 100 implants per year, and some of us place less and some of us place many, many more, we're going to assume a 5% failure rate. So we have 5 implants that fail. If we charge $3,000 for the extraction and the graft and the implant placement, and that's just going to be rough numbers, and we run a 50% overhead, not including our doctor pay, then we're going to have $1,500 in terms of revenue generated for that procedure. So let's allocate that the extraction and graft and implant takes 90 minutes, and then you're going to see them 2 weeks later for a suture removal. So from a suture removal perspective, it does not take you half an hour, but the math is based on that amount of time in your operatory. So the time in the operatory is what we're calculating, and it's the amount of revenue that can be generated through that operatory. So for half an hour, you're going to schedule for a 2-week suture removal. And then you got a 6-week PA. You're going to get a quick check PA, probably tell the patient everything is fine. And so the profit before paying the associate is $1,500. And let's assume 33% of adjusted production, so you pay your associate $1,000 for it. Well, you got a profit of $500 on a $3,000 procedure. Now let's say we have to remove the implant, and we have to graft, and then we have to repair the case. So some people are thinking, okay, you're going to have a net zero on this thing. And that may or may not be true. But you have 60 minutes to explant and graft, then 2-week suture removal, 4-week membrane removal, 3-month CBCT, 3.5-month implant placement. Then you're doing your 2-week check. Then you're doing your 6-week PA. So the additional cost to the failure is $1,500. So now we're at a net loss of $1,000 on the procedure, plus or minus. And so that's not where the hemorrhage stops. Okay? So there's something that's ubiquitous throughout every single business, and there's something called opportunity cost lost. So the opportunity cost is going to be the cost or the revenue that could be generated in that operatory. So the general practices, if they're a GP practice, is maybe $200 to $300 per operatory per hour. And if you get into surgical and specialty procedures, you might get to $500 to $1,000 per hour. And then if you're a full arch practice and just focusing on high revenue producing procedures, you might eclipse the $1,000 per operatory per hour. So if you spend 4 extra hours repairing this case, then you have a loss of $2,000 to $4,000 in addition to everything. So the net negative impact for your failed implant is $3,000 to $5,000 for that one implant. Now you look at the annual impact on your 5 failed implants, and you've lost the profit, right? Not what you paid your associate or what you paid yourself as a W-2. You've lost the net profit for the next 30 to 50 successful implants. And that doesn't even factor in the reputational cost of failures within the practice or the stress or the stomach lining you have to give up. And so we're going to cover how do you improve your surgical outcomes by reducing errors. And there's a few things we can do from a clinical perspective to really dial this in. And we're not talking about a 50% improvement. We just want to give you 4 or 5% here or there. And that 4 or 5% can have real ramifications for your businesses for the next 5 years, 10 years, 20 years. So we improve our quality of life, we decrease our stress, we increase our revenue and profit, we enhance our reputations in the community, and then we have professional confidence. And this is one thing I really want to hone in on. Through our courses, we do a quick poll of, hey, why did you sign up? And the vast majority of patients want to do the best thing they can for their patients. Or our vast majority of our attendees want to do the best thing they can do for their patients. And a lot of it is confidence. It's via the Hippocratic Oath, right? We want to do the best for that patient. And so they sign up for these courses, and they come learn training from us because they want to have the confidence to get to the next level. If you're stuck at level 1, 2, and 3 with a lot of failures, you may not have the confidence to get up to levels 4, 5, and 6. If we can teach you today how to do a couple of single implants, your 1s and 2s, have a 97% success rate in your practice like Dr. yourself have, well, then you might have the confidence to go to that next level, and of course the revenue and all that to pay for the CE. There's something also that's ubiquitous throughout different businesses called the Dunning-Kruger effect. So the Dunning-Kruger effect is essentially you start anything, and you start to do volume, and you start to get good. And that's actually when you become the most dangerous, because you start to cut corners, or you start to get comfortable, or you start to get complacent. And so what we're going to do is everyone in this room is going to hit the Dunning-Kruger effect with anything that you're going to implement. Our job here is to just shorten the duration of that effect. So for me, I was a cocky young doc, and the Dunning-Kruger effect for me was very, very long. And we've learned a lot about managing complications through managing hundreds and hundreds of patients over several years that we've been teaching. And so we're going to cover a lot of the common misconceptions and the common problems you're going to encounter in your single implant placements, and we might touch on a few full arch concepts as well. And so it starts with case selection. Let's just assume the general mass population is normal, and we're not going to speak about the outliers that are sometimes the toxic patients that just exist. So case selection, we got to pick the right cases in the beginning, and as you get a little bit more comfortable, you can start tackling the more complex ones. Case preparation. Me and my surgical assistant will sit down and we'll go through the case, and I'll say, hey, I see D4 bone here. I think I'm going to make a lingualized incision. Make sure you have this. I'm going to under-prep the osteotomy. Make sure you have these 3 implants in the room, and I'm thinking about a custom healing abutment. So we run through the case ahead of time. If you do this enough, the team will put you on their shoulders, and they'll actually volunteer different things and different provocations and different things to consider in the procedure, and they will make you more successful as well. So your pre-surgical breakdowns are going to be huge. We're going to talk about efficient scheduling, right? We're both GPs. There was a time I had ortho checks and checking triple hygiene next to a full arch, and I was just learning how to do full arch. It is insanely stressful to do all of that. So how do we schedule efficiently so you have the time to make it successful? And there's a version of stress that's important where it will strive and push you for more. And then if too much stress is occurring, you'll be in distress. So the goal is to have enough stress present that pushes you to achieve more without getting into the distress kind of category. We're going to talk about advanced clinical techniques. That's why we're all here. That is going to be the focus of today's presentation. And then comprehensive post-operative follow-up. I will tell you the largest and the most massive failures I have had have come from post-operative follow-ups and mistakes we have made. We missed an antibiotic. The patient got scheduled at 4 weeks versus 2 weeks. The smallest thing in the world can send your case spiraling, and then you're going to spend the next 12 to 15 months cleaning it up and doing the reconstruction. So if we can follow sound techniques and make sure we got the systems and protocols dialed in, you're going to avoid a lot of stress, you're going to save yourself stomach lining, and we're going to have a good experience with our implant placements. And then full responsibility for patient outcomes. Now, granted, patients will do all sorts of stuff to your surgeries. So we all know that. What I'm saying is let's take full accountability for everything, because through the process of really understanding why the failure occurred, we can internally reflect and make our systems better. We can figure out the breaks in our systems, so then the system in our practice improves significantly. And so Dr. Briskie is going to take over and talk about the mindset for implant success, and we're going to work through some cases. If you guys need, at the end, I think we have a QR code where you can scan and have the whole presentation, so you don't necessarily need to take pictures or videos or anything like that. We'll provide everything for you.
Dr. Dhoon, I think I'm going to cancel those occlusal fillings on my schedule next week with the All-in-X. I think I'm going to focus on the surgery. Okay, clear. Thanks. So what's the mindset for implant success? We're going to talk about implant stability and achieving optimal torque values, which I believe is 45 Newton centimeters. Let's talk about understanding spinners and low torque and the key causes of spinners. Over the last year, I've placed about 400 implants in my private practice, and I got 4 spinners. That's one of them. We will chat about some anatomical considerations, and this one's really important. So Dr. Dhoon and myself, we do encourage people to sometimes slow the speed of your drill down to 50 Newton centimeters and 50 RPMs, enough to feel the bone. And the reason is you're going to be avoiding some anatomical important vital structures. So if you spin a burr and it's winding down the bone, it'll actually stop when it gets to the maxillary sinus floor. It'll stop at the nose, or it will bounce off the lingual concavity, therefore protecting those areas. I have still to yet perforate a lingual cortex over my last 800 arches. It's because of the way that we drill and feel the bone as we're doing these osteotomies.
Yeah, one thing, I just want to say that again, because the slow drilling protocol and going at 50-50 has changed the trajectory of how I do my surgeries. So the lance spur goes in at high speed. That's fine. After that, unless it's D1 bone, you go in at 50-50. Saline on, saline off, your choice. If you're going to hit a cortical plate, if you're too far lingual, if you're too far palatal, it won't perforate the palatal bone. So all it'll do is rotating, and it will stay in place. You won't advance apically any further. And then all you need to do is redirect your handpiece, and it'll start gliding down. So the speed and the bone will guide your drill down along the cortical plate. Let's say you hit the submandibular fossa, right? Some of them are very exaggerated in your first and second molars. Sometimes you'll place an implant, it'll bottom out on that cortical plate, and you can't drive your implant in any further. If you run at 50-50 and you reangulate, it'll slide right down to the depth that you're anticipating, so you don't lose your bearings when you're doing your surgeries. And the same thing with the sinus and the nose. You'll hit those cortical plates, and sometimes we'll perforate it. We want bicortical stabilization. But sometimes if you go at 2,000 RPM or you go at high speed and you perforate it, you're perforating it at an uncontrolled speed and at uncontrolled depth. So if you go 50-50 and you stop and you're right there at 12, you know you're at 12 millimeters to the cortical plate. Now you know the length of the implant you're going to pick. And then you can, in a controlled fashion, perforate that cortical plate. So it's a protocol that Dr. Briskie brought to the group, and it's something I've been doing ever since, and it works very well. So I encourage you guys to test it out. Just consider it a recipe. If you guys have your own recipe and it's working really well, that's amazing. If you want to go home and try out another way, it's just different things you can consider to add to your armamentarium.
Yeah, we'll show some videos on each of these bone scenarios, like D1, D2, D3, D4, and how we drill. Yep. Next.
And then all questions we'll definitely take at the end for sure.
Yep. So what are some challenges with the grafted bone? A grafted bone, we can't place an implant at the grafted bone, right? 100% grafted bone, we're not going to get the stability we need. So what are some techniques we can do there? Also, importance of accurate CBCT reading. So before every full arch surgery that I have, I'll plan every implant on that CT. I'll select my sizes, I'll pull those implants, and I'll put them in the back of the room. My goal is to have my surgery before the planning and after the planning look exactly the same. That means my game plan was spot on, and also my system doesn't have to return the implants, right? More homework to do for everybody. What are some challenges with low torque? A spinner, I would qualify as something that you're putting the implant in and you can actually spin it with your hand, right? So that a hand torque is about 7 to about 12 Newton centimeters for most people. So if you can spin it with that, I call that a spinner. If something actually has lateral movement to the implant when you're spinning it in, so if you put that torque wrench on, or the hand driver on it and it moves side to side, I would probably encourage you taking that out. Also, low torque implant, I will qualify as anything under 25 Newton centimeters. There are some statistics that show anything under 30 does have a decreased BIC or bone implant contact, right, which can lead to implant failure. So let's focus on primary stability. Placement of a cover screw, I would recommend it anything under 25 Newton centimeters.
Yeah. One thing I want to add to this is when you do your case plan, your pre-surgical plan, and you think low density is going to be a potential issue that you're going to deal with, like it's a D4, D5 case, then automatically in your pre-surgical breakdown with your assistant, you're going to be considering a more lingualized incision. So why do we want a more lingualized incision, right? We want to, A, be able to roll more buccal or keratinized tissue to the buccal. But number two, if you're putting a cover screw on an implant, you don't want your incision laying over metal. That's when you're going to have an increased risk for a fistula, or you're going to have an increased risk for a microscopic opening where bacteria can seep in and create crestal bone loss. So if the bone is potentially going to be a softer quality, you may want to consider starting it more palatal or lingually, so then the incision approximates not over metal, so you're more likely to get closure without having some of these issues. Because every time the patient comes in and you got to keep it clean, you're taking $100 or $200 or $300 and you're just lighting it on fire to maintain crestal bone. So we got to think about everything holistically. At the end of the day, we want to give you the clinical resources, but we also want to look at it from a macroscopic view as we are running a business also.
So there is such thing as making something too lingualized of an incision, right? Because if you have too lingualized of an incision and you try to put a healing abutment on it, you have this bulky tissue that's bunched up on the front side of your healing abutment, right? You can introduce soft tissue issues at that point in time with soft tissue infection. We do have a really cool video. I go into depth on healing abutment selection on our YouTube page. So if you want to listen to me talk 20 minutes about healing abutments, feel free to jump on there. Also, too, with tissue closures, a vast majority of the time I'm doing a periosteal release to gain just very passive tissue closure. I've noticed so much better healing in my cases in terms of bone maintenance.
And just to qualify that comment, periosteal releases don't mean the big block grafting periosteal releases. It can sometimes just be grabbing the tissue with an Adson forceps, getting a curette, and pulling and stretching the tissue so it tears the periosteum ever so slightly. All it does is loosen up the tissue on the buccal so you can approximate with suturing a little bit better. It just releases tension in that region.
Which is 10 millimeters below the free gingival border, right? So we're not inhibiting any bone growth. So make sure the periosteal release is deep enough. So let's talk about some healing abutment risks. If that implant was 25 Newton centimeters, right? And would you feel 100% comfortable tightening it back on during its lowest stability, right? Between week 2 and 8? Maybe, maybe not, right? It gets pretty nerve-wracking. So I used to lose a lot of sleepless nights thinking about these scenarios. I'm like, oh my God, what do I do here? Like, what if the implant comes out, right? But if we focus on primary stability, we just don't have these issues. What are some patient behaviors, implant failures? Obviously, we'll get a patient 1 or 2 that will come in and they just like rip down their lip during the full arch and like, oh, what do you mean I wasn't supposed to do that, right? But the vast majority of the time, I think with proper tissue releases and proper implant placements, I think we can protect the patient from all these complications. We're going to overview bone drilling protocol. We're going to show you guys some videos on how to assess bone density, what type of bone is it, right? Also tactile feedback. We want you to feel the bone, right? We don't want you to just drill in and out in a hole, right? We want you to actually understand what it feels like to drill a hole in D1, D2, D3, D4 and properly undersize that osteotomy so we don't get spinners.
And this is going to be one of the reasons why we're an advocate of freehand versus guided. There is zero knocks on guided implant placement. I just think one of the things you give up is the ability to learn the tactile sensation when prepping freehand. And there's a lot of information to be gathered from going freehand. So something I do in my practice to standardize the quality of care with my associates is I'll have them do a guide with a pilot guide, and then I have them finish everything off freehand so they still get the tactile sensation in their hands. So if, God forbid, the guide doesn't fit, they have the skill set and the knowledge to move things to the finish line by themselves.
So here's CT. The one on the left, you can tell the bone on the inside and the outside is the same color, right? That's D1. You can't even see a shell, basically. The one in the middle, somewhere between D2 and D3, depending upon the case, sometimes it's hard to tell. You'll see the outer layer, and you'll see the inside is just a little bit more lack of density. The one on the right is the one I'm like, what time is this patient at? Can we reschedule them to next week? Right? So these are the ones you're like, oh man, how do I actually get stability on these without having to risk losing the implant? So CTs are the first redundancy in your planning. The second is going to be a flute check to see what type of bone is at the end of your drill. And then we do recommend in a lot of scenarios using a smaller drill, something like a lance, something 1.5, a little bit sharper, a little bit thinner. That case right there to the right was for a Neodent 2.9. I don't think I would have been able to get that. This one's hand guided, by the way. I don't think I would have been able to get it if I started with the 2.0, right? So some scenarios you do want something a little bit more precise. The picture on the right side, that is D4 bone after I took the burr out. There's a little bit of blood and a couple of small pieces of bone particles, right? This is when you should say, uh-oh, that's actually a 3.5. I think I already over-prepped my osteotomy here, right? And the one on the left is somewhere between D2 and D3. So we're going to show a case with D1 bone. D1 bone with Neodent is recommended at 800 to 1200 RPMs. And sometimes we do find it smart to slow it down a little bit to understand the bone density better. So you see just white bone, right? White bone, you should be thinking, man, this is D1. Maybe I shouldn't undersize my osteotomy, right? Typically, we see some docs will drill a hole, and they'll drill, let's say they're placing a 10 millimeter implant. We drill to 10 millimeters, we go to place the implant hits the bottom of a brick wall, and it starts to spin, right? That's another way you can get a spinner. Spinners are not just from D4 bone, it's also from D1 bone. So implant depth, what is implant depth? Implant depth, I think, would qualify as the implant size plus 2 to 3 millimeters, right? Especially in D1 bone cases. Now, placing an implant in D1, what can also happen is you're torquing your implant down, then it gets to the point where you almost have to put your wrist in it, right? Don't do that. Neodent implants are amazing implants. They're very aggressive. But you could actually cause a cold weld with the driver inside the implant and have it snap off. What if you do that? That's a really bad day, right? You have to try to find the implant out to get that one out. So drilling adequately depth here with D1 bone, very, very important, and not over-torquing the implant when you're placing it.
Yeah, and when you're placing an implant, I want you to consider the alveolus as the implant drives in is expanding. As soon as you stop rotating that implant, the alveolus is going to contract. And if you're in D1 bone and you have a lot of pressure getting exerted into this and you stop, it will contract into the threads and it will get welded in there. And so sometimes you got to try to find it out. So with D1 cases, do not over-force the implant in. Take it out, drill a little bit more, wider diameter, more depth, and then try again. Okay, D1 is sometimes even harder than D5. There's a lot of nuance to it, but at the end of the day, if you plan your CT, you look at the bone and the flutes of the drill, you're well aware of what's happening in real time so you can handle it and not run into these situations.
Yep, so most of the time with these, you're gonna have to use a plus drill, right, for the Neodent kit to actually get this thing to go down. D2 bone. Here is a picture, is a video now of lance drill going down D2 bone, and we'll show what comes out. D2 bone, I would qualify as red and white bone on your drill. So you take it out, you say, oh, there's red and white bone. It's not just white, right? Or it's not just red. So you do know there's quite a bit of cortical still inside there. This is one where you're also going to most likely go towards your last burr, right? Not the plus size, but your last burr.
And then you can always under prep your osteotomy. So maybe you don't go to your last burr, but maybe you just take your last burr in halfway. So then under prep, then drive the implant in. If the implant bottoms out and you feel a lot of torque, take the implant out and then take that drill in all the way and then retry your implant. You can always take the implant out and go back in, but if you over prep the osteotomy and you lose stability, the cascade of complications that may arise later down the road are going to occur. So that 2 minutes can save you hours, if not thousands of dollars in the future.
Here's a video somewhere between D2 and T3, right? Sometimes we don't know what it is exactly.
Okay, and this is our slower protocol on this one because the bone density was soft.
Now watch this here. It's actually hitting the bottom of the nose, and then it reaches the point where it would like pop through. So this drill right here has more bone particles on it. It's a little bit more red. So I would say a mixture of red bone. Red bone would be qualified as D3. Is that the one with the nose? No. So if you notice when you're drilling slower, you see how that burr kind of stopped when it hit the bottom of the nose there? One really important key point that I would really encourage everyone to remember here is if you use a flat burr, see how the 2.0 twist is more flat, and then the 2.0 lance has a tip on it? So I would encourage you guys, if you want to feel where the cortical bone is, use the 2.0 twist, because it'll bottom out and stop. Now, the lance is so sharp that that point will go through that bone, right? So if the tip goes through the bone, by the time you see the drop, you're about 3 millimeters away. So you're inaccurate up to 3 millimeters. So if it popped through at 10, right, and you thought it was 13, now your implant has perforated the mucous membrane, and your tip of your implant is more than 3 millimeters into the sinus or into the nose. So be careful there.
And a general rule of thumb is you can have an implant into the nose and the sinus 2 millimeters without having to augment or do anything else. You start to invade the space a little bit more, you're creating like a chronic irritant in the area, and it may have a concern. Sometimes it's okay, sometimes it's not okay. We're talking about small percentages here. We want to make sure we stay within the confines of like what we're teaching.
Yep. This one's D3 bone. So D3 bone, Neodent was very smart. They already recommended us to drop the speed down even in their manufacturer settings. They recommend 500 to 800 RPMs.
And in the beginning, do you see how I pushed the drill in? So when it cycles and loops back around, I pushed intentionally a little bit harder to do it for educational purposes. What they say is about 8 to 10 pounds of pressure per square inch if you're going to push your drill. Well, what does that even mean, right? It just means push it hard enough where the patient's head kicks back a little bit. So if the patient is sedated, don't worry about it, right? They're okay, they're sedated. If they're not sedated, inform them, hey, I'm going to put a little bit of pressure here, don't worry about it. And then you push enough so their head kicks back. That's the push test on every drill. If the drill is going to push to length just from pressure, there's no point in rotating the drill. There's no point in removing bone. Now we're just condensing it with our drills.
Yep, so it's a very little rock, side to side, right, with an apical push. All right, we're not trying to like jerk the patient's head back, right? Don't do that. But be very gentle at the same time. But what if you're drilling here and it just sinks right in and you're like, oh, I think this is D3. Then you push and the burr just went right in. You're like, oh, we were actually wrong. This is D4. Uh-oh, maybe we should stop drilling right now. So let's go to the next video. This is more D4 bone, and same thing, 500 to 800. Now, there are several cases where Dr. Jude and myself will push a 1.5 millimeter lance in, and then we'll push a 2.0 burr in. And all you do is you take a 3.5 millimeter burr at a higher speed, and you just outline with 3 millimeters into the top of the osteotomy where you're going to want your implant to go, and you're putting like a 4.3 by 13 in, right? So I have a protocol for myself that I do. My most distal implants are always 4.3 by 13s with Neodent. It's an amazing implant. I think I always get stability most all the time. But if I put that implant in and I get about 30 Newton centimeters, I actually take it out and put a 5 by 13 in, and I will get 45. Now, if I put a 4.3 by 13 in and I get 15 Newton centimeters, I take that out and I put a 5 by 13 drive implant in. And that has pretty much always gotten me to 45. So do spinners heal? Yes, we all know that spinners do heal eventually, right? But what is the most accurate way to measure that? You'd have to have an ISQ device, you have to uncover the implant, but there's no guarantee that that implant has enough bone to implant contact for it to actually heal. So studies show you need 50 to 80% BIC just for an implant to heal, so you need enough bone around the implant threads for it to properly integrate. So that means primary stability, right? It's a very important condition for integration. Dr. Dhoon spoke my language and all that financial loss there. So I think I would like to never have a spinner again. One risk that you get without a very high BIC is fibrous encapsulation, which I'm going to show a photo of. The implant can integrate fibrously, right, with granulation tissue around it because of the lack of bone to implant contact. Micromovements in excess of 150 micrometers can lead to fibrous encapsulation. That's the statistic. Here is a picture. Of course, bad things happen in courses when you work on family members. So this is actually my hygienist's dad that one of the implants failed on. I'm like, oh, great. You know, and I have I have to answer all my hygienist questions now on why this implant failed. But look at the picture, you can see all the fibrous tissue, and you can see the threads, the indentation of the threads around it. So this implant is 100% encapsulated in soft tissue.
Okay, and then what are you going to do in that situation, right? Are you going to just curette it out, graft, and then come back in the future? Or are you going to curette it out and place another implant? So if you're going to curette it out, make sure you are absolutely sure you have all those little fibers out of there. So for those of us in the room that do endo, right, the BMI, where you brush stroke and paint all the parts of the canal, treat the osteotomy that you're cleaning out in that fashion. Take your drills and paint the walls and the osteotomy that you're cleaning out, so all the little fibrous tissues get out of that site that you're cleaning up. So it's all native bone now. And then you can upsize your implants. Neodent has some very aggressive threads in their drive category. So just pick a drive implant, size it up, place another one, keep the whole project moving forward.
So what makes an ideal implant system, right? It has to be platform switched, internally indexed, conical connection. Neodent's is 16-degree Morse taper, right? So we have a very good stability there. It needs to be versatile. Well, I want something with single and full arch. I don't want to be pulling out multiple implant systems in my practice. It's just too much to handle. I want something narrow, which Neodent has a 2.9 now. Those are actually pretty stable ones. Large diameter, 6 and 7 millimeter implants. We want something high initial torque, something tapered. Also something really cool in Neodent is the drive implant. I think it's underutilized. It's completely compressive in the thread design, which we'll talk about. Nobel compatible, therefore you can use aftermarket stuff like photogrammetry, right? You want the top multi-unit to be Nobel compatible, so you can fit other things on top of it. Use the prosthetic selection, a decent cost, and you want a tissue level implant too. There are a lot of scenarios that I place tissue level implants. So the importance of selecting the right implant based on bone quality, 99% of the time I'm placing a helix. It's for 1, 2, 3, and 4 densities. The 6 and 7 is actually a little bit different. It's meant for a D3 and D4 bone. And let's compare the helix and the drive now.
So the helix is your workhorse. If you're going to stock up on anything, stock up on a lot of sizes of the helix implant. So the apical half of this implant is a triangular thread. So imagine it's just a cutting thread. For those of you who have already placed it, when it's going into the osteotomy, it is grabbing the bone and it's actually physically pulling the implant in. And so that's what I love about it. It goes exactly where you want it. And if you're going for bicortical stabilization, it's narrow enough and a cutting edge on the end where it will tap the cortical plate and then bring that implant into a bicortical stabilization. And then the top half of the implant is a trapezoidal thread, right? So that's a compressive thread. So usually speaking, when you're placing that, you get halfway in, the implant starts to grab those trapezoidal threads, you're going to feel the torque go up significantly. So there's a couple of tricks you can do in softer bone protocols, where if you're driving the implant in, and let's say you place it at 30-30 or you place it at 50-50, you put your foot on the pedal and you drive it in and you stop and let the bone contract a little bit. Then you put your foot on the pedal and drive it in a little bit and let it stop. What that's doing is it's tapping the implant in and it's condensing the bone as it drives more apically. So if you were maybe going to get like a 30 on the implant by just driving it in all the way continuously and automatically, well, what's going to happen via this off and on technique, you might go up to a 40 or 45 just because your technique of placing the implant was appropriate for that density of the bone.
So that means you want to place the implant at 30-30. So 30 RPMs, 30 Newton centimeters. Because once that thing starts going, it's not going to stop, right? So you really want to understand what bone density is. You have to place it 30-30. And a lot of the time, if it's going down, you could actually stop it and then try to go again, and you'll notice it just won't advance because the compressive threads now have got it, and it's stopped its momentum on the self-threading cutting portion. So you actually have higher stability than you initially thought you did. The drive implant. So the threads on this, if you look really closely, it's a shape of a square. And the threads have a rounded apex. This implant has a rounded apex. So this implant is purely for compressive, right? Compressive and kind of like compressive forces. It's meant for D3 and D4 bone. That's what I exactly use it for. So I don't use these in D1 and D2. I just don't. I think you could risk breaking parts, right? It doesn't self-tap. You can get a spinner when it hits the bottom of the bone. So I use helix when it's needed and drive when it's needed.
Yeah, so what Dr. Briskie said is if you're going for bicortical stabilization on a drive implant, it will not tap into the small osteotomy or the small hole you've created in the nose or the sinus. So you sometimes have to upsize that part of the osteotomy so the apex of the implant can actually grab into it. Because what's going to happen if you put a screw into drywall and then you just keep rotating that screw? It's going to auger out all the drywall. So if your drive implant goes into the bone and it bottoms out on a cortical plate, it's going to rotate and it's going to auger out all the bone and you're going to lose all your stability.
Now you have D4 bone.
Now you've created your own D4 case. So you have to size it up a little bit and then let the apex grab into the bicortical stabilization.
Yep. So let's keep enough implants on stock, right? I think Neodent would agree with this, right? But never abort an implant placement due to you just not having it, right? That's a costly one in itself. So always plan your implant and plan it so that way you could go shorter or you could go longer with the proper implant stock. So you should always have 4, I would say 5 implants on stock, because I would keep one shorter and more narrow and one longer and more wider, but I'd also carry one in a drive type of implant, right? Because you never know what scenario you're going to come up with. And I don't ever want to have I don't like when patients have the experience like Gene did, right? I want us all to not give dentures. So what do I keep? This is my own implant stock. I actually do it with bookshelves. These little bookshelves from Amazon. And I have my main sizes that I place. My main sizes for implants for full arch are 4 by 11.5, 4 3 by 13, and 5 by 8s. In doing that, I can upsize or downsize accordingly with those ones correctly. I'd never go too long or too wide in the beginning because you want to reserve that implant for later. For drive implants, I do recommend stocking a 5 by 8 in a drive, a 5 by 10, a 5 11.5, and a 5 by 13 in drives. Those are the ones for D4 bone cases typically.
Now consider, some of us are doing a lot of full arch, some of us are doing a lot of surgery. Yeah, maybe you want to stock 60 implants. But at the same time, if you're younger and you're in the very beginning of your journey, I think I was talking to someone about who just did their startup on Monday, maybe you don't stock 60 right off the bat. Maybe you talk to your local rep. You say, hey, I have a case coming up. Can we order X, Y, and Z for this case? Let's control what's on the balance sheet. Let's control what's on the P&L. If you look at larger businesses like Dell, they don't keep a whole lot of stock and inventory, right? They're not going to keep a lot of computers on the shelves. They're going to produce what they need to get what's out for the consumers, because they know that every minute something sits on the shelf, they're losing money on that business. So granted, we're a much smaller version of that, but let's not overstock our inventory so much if you're in the beginning of your journey. Now, when you get to the place where you're being proficient and you're placing a lot of implants, well, yeah, then at that point, start stocking everything because you're going to cycle through that a lot. So there's a whole system and a sequential way to add all of this to the armamentarium so you can build your implant program in your practice in the most logical way.
Yep. So what size should I keep at minimum? I would recommend something along the same bone to implant contact in terms of measurement. So I like 3 5 by 13, I like 4 3 by 10, and I like 5 by 8. So if anything, stock those 3 sizes. That should take care of you in almost any case. And if you want to, start to stock a few other implants as well.
And then we'll grab all questions at the end. But yeah, definitely please write it down.
So what happens when the tissue opens? Do you do a wait and watch approach? Do you just let the junctional epithelium granulate in? Or when do you actually decide to resuture the case? Or when do you have to nurse the case along? And when I say nurse the case along, the research articles show between week 2 and 8, the implant stability does drop, right? So if you have a low torque implant or a spinner, what do you do in that time zone in order for that implant not to become lost, which will show a couple techniques that we have. So a few of my, and also too, if you do choose to close it, like if any full arch opens for me, I'm immediately closing it. I'm just not willing to risk the loss of an implant, all right? Because you could still have bone loss. Once the incision opens, biology does attack the implant if it doesn't granulate over it properly, because the implant does need its correct biological width above it. So if it doesn't have 3 millimeters of biology above it, you will get bone loss down to make that measurement around the implant.
And one caveat on the biology, imagine the perio probe coming straight down like we all traditionally do, 3 millimeters there. But also from the width perspective, if you take that perio probe and you puncture the tissue, you want 3 millimeters there as well. You want to insulate the implant horizontally and vertically with biology and with soft tissue.
And that a lot of time with incision openings happens on the lower arch in the anterior. The anterior mandible is the thinnest, right, in terms of width. So you have an opening there, your implants will get some bone loss. So I like to use 1% metronidazole gel. It's a topical antibiotic. And I also use Clocis. Clocis is hypochlorous acid. That during COVID time, they put it in fogger machines, and they said, oh, we clean our planes to get rid of COVID. It was just hypochlorous acid. It was nothing special. I love this in my rooms. I keep a 64-ounce pump bottle in every single operatory. You can get it from like Darby, like for $60, you can get 4 64-ounce things of it. And you just pump it into a little cup, and you can use it to clean areas, incision line openings, dry sockets, all that type of stuff.
And that metronidazole gel, it works wonders, and you can send it home with the patients, and they can apply it on a Q-tip, put it right on the affected area, and you're going to watch the biology and the bacterial infiltration in those areas go down significantly. And if we can control inflammation, this inflammatory cascade is just degradation. So if we can control that, this is one of those things that will get you that extra % or 2.
So PRF does provide angiogenesis. There are articles that show that. So anytime you're going to be closing incision, I always draw blood. I put PRF over the top, then I close the incision. I also recommend attacking these infections systemically. So I will increase the antibiotic coverage a little bit for 2 amoxicillin plus metronidazole. Now I'm getting all the gram-negative anaerobic coverage as well. Like Dr. Dhoon said, you can give the patient a little bit to go home with. Just charge them for it, like $20 is what I do. I have it compounded, and then I charge the patient $20. I'm not trying to make money. I just don't want to lose a bunch of money at the same time.
And then with the antibiotics, we have patients who have like penicillin resistance. What I've found is if you just give them a Cipro, or you give them a Z-Pak, or you give them something else that's outside of the amoxicillin family, couple it with metronidazole, and you're going to watch some of those chronic inflammation, or those ones where you just have a little bit of purulence, you're going to watch those go away quickly too. So the metronidazole acts as another blanket from a broad spectrum perspective to protect the implants in these types of patients. And quite frankly, in patients that have high comorbidities, and I think that's that risk factors are adding up, I'll automatically just give them the amoxicillin and metronidazole from day one.
So that top picture right there was incision opening on a lower arch. Boom, I'm immediately going back to close it. So I lay PRF over the top, I close the incision. This patient actually, I had 3 All-on-X's last year that opened an incision. This was one of them, and that patient opened up 3 times. So she was actually a bit more different. She had such a strong mentalis muscle and lower lip muscle that she would do this motion with her lips and create an orange peel chin and a downturned face. And I actually had to Botox her just so she wouldn't open that incision. So you sometimes will have to think outside the box a little bit, right? But again, same thing, always blame yourself first, right? Humility, say, hey, what can I do better? Then sometimes it actually is the patient's fault. That bottom picture, if you look really closely, there's a little pimple there, right? We have all seen posts on Facebook where it says, doc goes, hey, placed this implant 2 weeks ago. I have a millimeter bone loss. What happened, right? But they don't show a soft tissue picture. And usually it's because the incision opened and there's a microscopic fistula going from the outside environment to the top of the implant, right? So that's why what Dr. Dhoon said, it's very important to have the proper incision, right? Which is mid-crestal but slightly lingualized.
Okay, and then in that situation, well, if we had 20 Newton centimeters of torque, we're going to be cautious about taking the cover screw out and putting a healing abutment on. But if we were able to achieve 45 Newton centimeters or higher, well, then take the cover screw out, put the healing abutment on. So you don't have to worry about spinning your implant out. So we're going to gather percentages of success, and we're going to open a lot of doors for repair in the future just by getting stability on your implant from day one.
Yep. So patient walks in like this, right? This is a week after you place the implant. Like, oh my Lord, right? Of course this would happen. And you probably are behind in hygiene and lots of other issues too, right? So the thing to do is clean the area. I'll rinse it with Clocis, something, and start to clean the area and see what's in there, right? Are you staring at the implants, or is it actually starting to granulate over? Now, if you have a spinner, you have two things you can pick. You could either decide to resuture that close and do a really good perios release if you think you can get it, right? Or you have to nurse this along until you're able to put a healing abutment on it, where when you put the healing abutment on, you don't actually unscrew the implant by accident, right? So what I did in this incision, this type of one is, I saw it granulating over, right? All right, cool, let's wait a little bit. So importance of very routine post-ops, like Dr. Dhoon said in the beginning, see this patient more often. I'm seeing them every week, right? To make sure, because the cost of an implant failure is very high, I'm going to nurse this patient along. So I bring them back for 1 week, and you start to see something different. So now you see this, right? You're like, oh, it is starting to work, right? But what's happening is you have a fistula now. You have a fistula that's on the top of the ridge that's connected to the implant. You're going to get a soft tissue infection here. So if this is a spinner case, same thing. You have to decide, am I going to try to let this granulate over, give the patient a closest rinse, also give them a topical antibiotic, a systemic antibiotic, and see if we can get this thing to granulate over, right? Until we can switch out the cover screw to the heel abutment. This specific case, I looked at the implant. This is actually from one of our courses. And I looked at the sheet. The sheet said 35 Newton centimeters on the implant. We're at 3 weeks now. I feel comfortable with 35 Newton centimeters to take the cover screw out and put the healing abutment on. So sometimes you need to switch it out. So we switched it out. I advised the patient to buy the rinse. I gave her a little bit of antibiotic to go home with, to nurse it along, and then came back a few weeks later, and it looks perfect, right? I took an x-ray at 8 weeks. On 8 weeks, we noticed 0 bone loss, even though we had occasion with the surgery, right? So this is the type of things that I think everyone in this room can do. Starting limiting some of your implant failures. What are some solutions to D4 bone now, right? So if we start to understand what the bone should look like, right? We understand the speed that we should be drilling, feeling the bone, but what if we still get one, right? There are a couple of techniques that we can use. Osteoidentification is one of them. I am not the biggest fan of osteoidentification, not because of the product itself, but because of the improper use of the instruments. So I have seen quite a few cases where a doc will call me and say, hey, I use a Versadrill in this scenario, and I say, why did you use such a big burr, right? If you use a 2.3 drill, you're already too big for a lot of these D4 bone cases. So quite a few of them, you're pushing a drill in, just doing a tiny little indent on the top of the ridge for the implant to go in, and you place your implant. So I see quite a time us over drilling still in those scenarios. And with osteodensification, they do work still, right? But you have to be careful. We've all seen some cases also on Facebook posts where a doc will place an implant, they did a sinus lift, and the entire area has a catastrophic failure, right? Because of the overheating of the bone. So just be careful, use it smart, right? Maybe use it in some D3 cases where it's meant to be used.
Yeah, my number one way to engage these cases is going to be cortical stabilization, okay? Sometimes it's bicortical, sometimes it's just cortical. So bicortical stabilization, we've talked about it, nose, sinus. We're not here advocating bicortical in the mandible. That's a much more advanced technique. Don't bother with that right now. From the perspective of cortical stabilization, we're taught via the Neodent system to place the implants 2 millimeters subcrestal. That system works wonderful unless you're in a D4, D5 case. So what you're going to notice is you're going to have 45, and the rat's going to go, and it's going to go 30, and then 20, and then 15, and then nothing. And what's happening? The implant is going subcrestal, and now you're relying on trabecular and medullary bone for stability, which there is none. So in some circumstances, I will leave my implant at the crest of the ridge, or just 0.5 millimeter subcrestal, because I'll go 45, 40, and I know what's happening, and I'm stopping. Also, Neodent has the short implant, and that could work really wonderfully over there. And I know, are you going to touch base on that?
Yeah.
Okay, great.
So a couple of things you could do is you could actually pack bone, graft, and then place the implant. Because what you're doing is you're trying to increase the bone to implant contact. So what I would do in that scenario is I would actually take a bone scraper, scrape bone, I would combine it 50-50 with cortical cancellous with autogenous, pack it in, and then place the implant. You're giving it a better chance, right? You're trying to increase the regeneration, increase the amount of bone surrounding those flutes. I've also done cases where it's like, hey, maybe another day is better. Maybe I do just graft this with some auto, right? Auto and some cancellous, and let this area heal for 6 months, then come back and place the implant. Sometimes that's a wiser choice than risking a catastrophic failure. A few times now, I've actually used the new tissue level implant. They're short in this scenario, where I push a lance, push a 2, place a 5x8 drive, and then still didn't get stability, but then I place a 6x8.5 short, and it would grab the crest of the ridge, just right on the top of it. And because it's a tissue level implant, it actually heals better with the soft tissue around the area, right? We're not going to get the bone loss by placing an implant even with the crest. So something a little bit unique, but I have used it a few times in that scenario, and it has worked for me.
And imagine what that implant looks like. It comes out. So the top of the implant is wider than the area where it junctions the bone. So God forbid the patient bites into something, they have a hollow mandible, or you're doing a sinus and they push that thing up into the sinus. Well, this type of implant is designed in a way to manage soft tissue, but also it counteracts force going into hollow spaces.
So look at this bone loss on these implants, right? How could this happen? Why did this happen? Is this pressure necrosis? I would argue no. So if you're placing an implant in D1 bone, right, and you get the implant down, a lot of the time what we do is we say, hey, oh my God, I got the implant in. This is a success. I'm going to leave it, right? But what happens is biology will attack the implant because we didn't place the implant deep enough. We get some remodeling. We can risk loss of the implant. So I would argue this is not pressure necrosis. This is from remodeling of the bone. So pressure necrosis, is it a myth? I would say yes. A lot of the articles say you could insert an implant up to 176 Newton centimeters before it prevents integration. So there is no significant effect on marginal bone loss at 50 Newton centimeters, and there is no significant effect on implant survival at 50 Newton centimeters. So I would go 45 or below. What are some complications that can happen? You could actually break the bone. So if you're muscling an implant in, what happens is it will have some lateral outward forces, and you risk some green stick fractures of the bone on the buccal. That is okay in itself, right, as long as you don't lose stability in the implant. But we don't want to be doing this. Also, broken implant parts. You can break drivers, you can lose implants, right? It can get very expensive. So don't muscle it in. Just go for 45, right? 35 to 45. So best practices, what we recommend is at least 35 Newton centimeters on every implant. I think everyone in this room is 100% capable of placing an implant at 35, at least, right? If we have the proper implant, the stock, the drilling, the knowledge, the CT knowledge, right? I think everyone in this room can do that. Also, suture technique, definitely release periosteum, get the closure that you need. Don't risk incisions opening. I also practice suturing. PRF and metronidazole gel, very important tools to use. I use them on a daily basis in my implant practice. Pre and post medications, things like antibiotics, steroids, right, ibuprofen, all these other things are very important. I do place all my patients on vitamin D supplements to get up to 10,000 IUs a day, up to about a week before, up until about 6 weeks after surgery, making sure they have the proper amount of vitamin D.
I would for sure remember the vitamin D. If you have a freak failure and you send them for labs, oftentimes what you'll see is a vitamin D deficiency. So like Dr. Briskie said, get them on the vitamin D right away. Also, antidepressants and other things are kicking up failure rates. So make sure that you're having a conversation with the patients. And when you're talking about someone's antidepressants, you want to say a version of, I know a lot of people take a long time to get their dosages right, so I'm never going to change another doctor's medications. So if you're choosing to alter it for any reason, make sure you talk to the physician who's prescribing it for you, because you don't want their life to tailspin because you're placing a single implant.
Yes. So importance of adopting the correct mindset, right? I think we all can do better and better and better, being very, very humble and never blaming the patient. Practical strategies for managing spinners. We went over quite a few things. Start drilling a little bit slower. Feel the bone, right? It's a learning experience to place an implant, and it always will be, right? This is like a 20, 30-year journey that we're going on together. So like a really famous rock climber said, you have to take the leap of faith and trust in yourself and your abilities. Only then can you truly discover what you're capable of. So what we recommend is taking a leap towards greater success rates, reduce failures, and better outcomes for all of our patients, right? That's our goal. That's why we're doing what we're doing. We're trying to create less experiences like Gene had, right, initially for her first 2 years, and creating more smiles on a daily basis. That's why we wake up in the morning. We wake up because it's fun to give people smiles again. They may not say thank you for the occlusal filling you did, but they sure will say thank you for changing their life. They caught this picture like right after we hugged. So
if you want, this is our personal contact information. We allocate 8 hours per week to talk to doctors about complications, their treatment planning, what have you. There's a quote about, and it's a cliche quote about the journey versus the destination, but someone added something that was really intriguing for me to consider. Well, it's also about the company you keep along the journey, and that's why we're all here. So definitely switch numbers with each other, take our number, make sure you reach out to us because we are sincerely here to help, and thank you for all your attention and Neodent for the opportunity. Thank you, guys.
Thank you.